Thank Dr. Mahinder Narwaria, Dr. Manish Khaitan, and Dr. Sanjay Patolia for this excellent conference and for giving me time to stand before you. It was again going to be mini-gastric bypass versus Roux-en-Y this evening, but now I think it will just be a talk on mini-gastric bypass. Just going to be a healthy talk, no debates. If we see the structure of mini-gastric bypass, it's a long narrow tube starting from the crow's foot going up to the GE junction, and then we hook this tube to the jejunum at around 200 centimeters from the DJ flexion. Going into the history of bariatric surgery, this is about more than 120 years back, Billroth tube, which was used for ulcers and gastric cancers. And a retrospective study showed that this connection has got something to do with the weight loss and some resolution of diabetes. And Dr. Mason, the father of bariatric surgery, he did a modification of Billroth tube into Mason's loop bypass. He decreased the size of the stomach and then brought this connection up. But there was a lot of bile reflux associated with this kind of loop connection. So probably because of that, the loop gastric bypass got into disrepute, and the same controversy was carried on to this bypass, which was started by Professor Rutledge in 1997, probably 17 years back. But all the new reports which are coming for MGB, bile reflux is not of much significance now. They are showing very low incidence of bile reflux, probably because of the long tube. And this Roux-en-Y, the gold standard surgery, which came into being for correcting the bile reflux of the loop connection, this biliary limb was brought down, but this connection made it a bit more complicated. Small pouch, multiple connections, mesenteric defects, more chances of internal hernias. Here we have a long tube and wide gastrogenic. Looking into the structure of both the bypasses, looks like both are gastrojejunostomies, but they are working in a different manner. Here our patients are happier because they can eat better. They can eat a moderate amount of food. As compared to a 30 cc pouch of Roux-en-Y, they have a wide gastrogen. We start them semi-solids on day 2 of surgery because they can swallow the semi-solids, as compared to 1 centimeter or 2 centimeter outlet of the Roux-en-Y. And then the bypass here, it's a pure biliary limb. All the 200 centimeter is the biliriopancreatic limb. But here, the biliriopancreatic limb is only 50 to 70 centimeters. Probably that would explain the better metabolic effect of the mini-gastric bypass, which now we can see in reports which are coming. So, as a trade-off, if we want to see which procedure we want to buy, MGB or Roux-en-Y. So this is beyond doubt. We won't compromise on safety, efficacy, reversibility, tailoring, and good metabolic effect and less long and short-term complications. As far as the safety goes, this procedure takes less time. So short time, less anesthesia, less complication, only one connection, less chances of leak, and easy reversibility, revisability. And we know obesity is a difficult disease. Patients will be coming with weight regain. And especially in the Indian scenario when the patients are paying from the pocket, we need to give them some kind of simple solution. Somebody is coming with a weight regain. So easy here, just take down the gastro-J, increase the length of the bypass. You can also decrease the length or put the stomach back to stomach. Easy to reverse as well. Looking into the data, safety and efficacy, Professor Lee, controlled prospective randomized trial. Look at the early complications, Roux-en-Y 20%, mini-gastric bypass 7.5%. No doubt, at 10 years, as he reports, it's simpler and safer and can be considered as a better efficacious procedure at 10 years as compared to Roux-en-Y. Look at Rutledge's data. 15 years, 78% excess weight loss. It's a strong surgery. Roux-en-Y reports are excellent, in excellent hands, but we have varied results. The leaks are ranging from 1 to 10%. See this big series, 2200 cases, recently published in 2013, shows 500 cases are required as a learning curve for Roux-en-Y. No doubt it's a relatively difficult surgery. 28,000 patients, recently published data from US, shows by all respects Roux-en-Y has got higher incidence of complications, all the complications. Another study recently published in JAMA, it is on relatively healthy patients to see the effect on diabetes for the Roux-en-Y. At 1 year, only 44% of the patients have normal HbA1c. This is for the low BMI patients. But they have 37% serious complications and 3.3% leaks. Look at this new publication of 1,000 patients by Professor Naum. Only 0.5% leaks in MGB. So seems to be all the publications which are coming. We have now 2 accepted papers in obesity surgery, about 1500 MGBs, 98% improvement in diabetes, and 85% excess weight loss at 7 years. So if we look at the long term, look at Professor Calvin Higa's 10-year follow-up of Roux-en-Y. It's showing 16% internal hernia incidence and 5% stenosis. This is at 10 years, in very good hands, Professor Calvin Higa. So subacute intestinal obstruction after Roux-en-Y, this is going to be a new chapter in the textbooks of surgery now. This is a well-known entity. But as we see Professor Lee's study at 9 years, he has no patient who had surgery for internal hernia. So what a fair trade-off in the long term. Another recently published study to see the overall healthcare cost, whether the Roux-en-Y and the lab band, they save some cost in the long run. After 5 years, you can see the graph going up. So they say that the healthcare cost is not reduced even after the patient has underwent Roux-en-Y. So the readmission rate, the complication rate is high. So there is a big question on the viability of the procedure. And if we see the metabolic component of MGB, look at Professor Tacchino from Italy. He's a big time BPD man, did about more than 2,000 BPDs, but now he's saying that MGB is more powerful than the BPD. The diabetes resolution is better, the weight loss is better. Look at other randomized controlled trial published, Professor Vijay Lee and Erkam Dean. MGB is clearly, as far as the metabolic concerned, it is better than sleeve and Roux-en-Y. So what is causing this poor metabolic control in Roux-en-Y? Probably if we look at the rule-in, when the sugar is entering, this is just a hypothesis, it has not been proved. What is required to absorb the sugar here? Sucrase is present in the small intestine, so it can absorb the sugars. So probably the sugars are being absorbed in the rule-in. And there has been a study to see the relative effect of malabsorption and restriction. Which one is playing a stronger role in Roux-en-Y? They studied the absorption coefficients of protein and carbohydrates. So what they say, the malabsorption is like 124 kilocalories are reduced because of malabsorption per day. But restriction is like 2,000 kilocalories are reduced per day. So look at the graph. So Roux-en-Y restrictive component is about 95% and malabsorptive component is less than 5%. And as the time goes, the restrictive component is going down. So Roux-en-Y is primarily a restrictive procedure, and it's very clear by now. And whereas MGB is a combination of restriction and malabsorption. So with this, I thank you very much.
Very good presentation. Kular. House is open for questions.
There is only one question from one observation from my side, Kular.
Yeah.
See, the internal hernia was more in that paper because it was a retrogastric Roux-en-Y repair.
Okay.
And the stenosis was there because it was done on a 32 French bougie. They produce severe restriction. The reason is that they believe that restriction is going to give you more weight loss. I'm not going into that thing. The complication rates were high and they were knowing it. It is there. Still, they are practicing the same thing.
I think you're right, yeah. But still, it's a matter of debate. Many people are putting ban on the Roux-en-Y, so they believe that the restriction is very much required.
Right. Only one question.
Yeah, a quick one. You said there's leaks actually. Leaks is like anything else. If you have been practicing well and you have been trained well, your leak should be low. In fact, Kelvin Heger's last 3,000 was no leaks. I didn't have in the last 1,500s. Therefore, it's like that everybody and all the trainees and residents of mine, they didn't have a single leak. Therefore, the training. And in fact, Mr. Lee and others you are quoting, they're all retrospectively. They trained over a period of time on their own. And they learned their mistakes. And then they moved to MBZ. And therefore, naturally, they are better. And the internal hernias, almost none. In the last 1,500s, none at all, for my own. Therefore, it is closure of the mesenteric defect, how they close it, and how they are trained to do so. That is more important. Therefore, once they are done well, there is no problem at all.
No, you're right, yeah. We have very good reports, as I told already, very good reports, but in very expert hands. You need to close the mesenteric defects, but internal hernias are a known entity with Roux-en-Y. That's beyond doubt.
Thank you. Thank you, Dr.
Thank you very much.
Yeah. I'll ask. Please. Please.